Dr. Roy Wade, Jr. is an assistant professor of pediatrics at University of Pennsylvania and a general pediatrician at Children's Hospital of Philadelphia. Dr. Amanda Bennett is a developmental and behavioral pediatrician within the Division of Developmental and Behavioral Pediatrics and a member of the Center for Autism Research team at Children's Hospital of Philadelphia. Dr. Sandhyaa Iyengar is a fellow within the Division of Developmental and Behavioral Pediatrics at Children's Hospital of Philadelphia. I will now turn the mic over to Dr. Roy Wade to share a bit more about adverse childhood experiences, or ACEs, and their impact on behavior and development.
Good morning. Adverse childhood experiences impacts the health and well-being of kids throughout their life course. If you're a child who was born to a mother who was abused or neglected, you're at increased risk for fetal death. Those children, if they experience adverse childhood experiences, are increased risk for things like developmental delay, behavior problems, and cognitive impairment. Transition into adolescence and young adulthood, those same children are at increased risk for mental health problems. But then their problems move outside of the realm that we traditionally associate with health, including problems in school and even involvement in the juvenile justice and later criminal justice systems. In adulthood, those same kids are at increased risk for mental health, but what the adverse childhood experience showed us is that they also have an increased risk for physical health problems, disability, and even early mortality. The work from the initial adverse childhood experience study showed us that individuals with as many as 6 or more adverse childhood experiences are at increased risk for early mortality. Likely the landmark study for us is the Adverse Childhood Experience Study. As a review, this study was conducted by researchers from the Centers for Disease Control and Prevention and Kaiser Permanente out in San Diego. The goal of the study was to look at the association between an adult's adverse childhood experiences and the risk for an array of different health problems. I've outlined those adverse childhood experiences on the right-hand side of this slide. They include essentially 10 experiences, including abuse, be it emotional, physical, or sexual, neglect, be it emotional or physical, and various household stressors, such as having a care provider with substance abuse problems, mental illness, domestic violence at the home, an incarcerated care provider, or divorce or separation. In total, 10 total experiences, which they use to calculate or create what they call an ACE score. It's a composite score ranging between 0 and 10. The researchers then looked at the association between the respondent's ACE score and the risk for an array of different health outcomes. This slide shows the association between a respondent's ACE score outlined on the x-axis or the bottom axis of the slide and their risk for cardiovascular disease outlined on the left-hand side of the slide. What you can see is a graded relationship between the respondent's ACE score and their risk for cardiovascular disease, things like strokes and heart attacks. What I want you to see here is that at every incremental increase in a respondent's ACE score, you see an incremental increase in their risk for cardiovascular disease. The researchers then went on to show the same graded relationship with an array of different health outcomes, starting with health risk behaviors such as smoking, drinking, drug use, and high-risk sexual behavior. Then moving on to mental health conditions such as depression, anxiety, PTSD, hallucinations, and suicidality. And finally, they showed a strong association with physical health outcomes. We already talked about cardiovascular disease, but they also showed the same graded relationship with things like diabetes, emphysema, cancer, obesity, liver disease, headaches, autoimmune disorders, sexually transmitted infections. We talked about disability, fetal death, and even early mortality. Highlighted in red are many of the leading causes of death and disability throughout the United States. The sobering fact of this slide is that if we want to really improve health outcomes for an individual who's in their 70s, what the Adverse Childhood Experience Study suggests to us is that we need to start when they are younger in terms of the environmental conditions that they experience. There are certain populations that are markedly increased risk for poor health outcomes. I call those individuals people who have experienced significant childhood adversity. From the Adverse Childhood Experience Study, it's mostly individuals who have endorsed 4 or more of these events. What you can see is that those individuals have a 4 to 12-fold increased risk for many of the health risk behaviors we discussed, nearly a 2-fold increased risk for many of the physical outcomes. Now, How does adversity get underneath the skin? This slide outlines how we think adverse childhood experiences translates into later disease and disability and social problems. Adverse childhood experiences, particularly if they occur during sensitive periods of development. As a pediatrician, I think of this between the ages of 0 and 6, when kids are undergoing rapid brain development. That increases the likelihood that they will experience social, emotional, and cognitive impairment as a result of their traumatic experiences. Looking across the top-end portion of this slide, that then increases the likelihood that they would adopt health risk behaviors, so things like smoking, drinking, or high-risk sexual behavior as a way to cope with their past stressful experiences or ongoing stressful experiences. You can then see how those behaviors will then directly translate into disease and disability. And the social, emotional, and cognitive impairment that they might have experienced as a result of their traumatic experiences then also can impact their risk for social problems and early death. Now, a parallel body of research has shown changes in your stress response system, in your hypothalamic pituitary axis, and your immune cell functioning that occur as a result of the experience of trauma as well, that then underscore these health risk behaviors and magnify one's risk for poor health outcomes. Now, before we go on, I think I have to talk a little bit about stress, because not every stressful event is an adverse childhood experience. So this was taken from the Center for the Developing Child. What you can see is there's positive stress. This is stress that results in brief increases in your heart rate, mild elevations in stress hormone levels. So these are sort of normative events, right? I think of these like vaccinations that I give a child. They're brief in their duration and have little impact on a child's lifelong health and well-being. Now, tolerable stress can be a serious event, such as a death in the family. The key point here is that they occur in the presence of buffering relationships that helps to mitigate the impact of these experiences. Now, when I talk about the impact of adverse childhood experiences, what I'm talking about is toxic stress. This is prolonged activation of your stress response system, and the key here is that it often occurs in the absence of protective and supportive relationships. What we find is that kids enter a cycle of toxic stress, where they're exposed to these traumatic conditions. They don't have the nurturing and supportive help from adults that they need to overcome these conditions, and they enter what we call a chronic fight or flight state that leads to changes in their brain architecture and causes them to be hyper-responsive in response to stressful situations, even situations that one of us might deem to be not stressful at all. That causes them to be exposed to more toxic stress and continues on in a cycle. There are three major areas in the brain that are impacted by childhood trauma. This includes the prefrontal cortex, which is your seat of executive functioning skills and regulates your thoughts and emotions. Your hippocampus, which governs your short-term memory and connects your emotions to your fears. And your amygdala, which is the seat of your fight or flight response. What we find is that each one of these areas, particularly, as I said before, if the child experiences these events during these periods of rapid brain growth, are susceptible to changes in the brain as a result of these traumatic experiences. What we see is that the hippocampus can actually shrink in size and the prefrontal cortex can actually shrink in size, while the amygdala can actually grow in size and become hyper-responsive. As a result, kids enter this hyper-aroused or hyper-responsive state to stressful situations, which then puts them in a chronic fight or flight state. Now, these following two slides are going to show you cognitive and executive functioning skill changes that result as an exposure to adverse childhood experiences. They were conducted amongst a group of kids who were born into Romanian orphanages, and as a result of their experience in these orphanages, experienced severe neglect. This first slide shows you cognitive skills, or IQ, for these kids who were born into Romanian orphanages and adopted out into foster care, who remain in those orphanages, and then they appropriately match control. What I want you to see is that every measure of IQ, verbal comprehension, perceptual reasoning, working memory, or full-scale IQ, those kids who were born into those Romanian orphanages, were either adopted out into foster care or stayed in those orphanages, have a significantly diminished IQ in comparison to their appropriately matched controls. We see the same sobering statistics when we look at their executive functioning skills. Here we see kids who were born into those orphanages and then and the kids who were never in those orphanages at all. And what you can see is those kids who were born into those orphanages and institutionalized and experienced severe neglect, as outlined in the green, have significantly decreased executive functioning skills as well. Here in a study by Bart et al., they show the association between various adverse childhood experiences outlined as risk factors. So they included within their adverse childhood experiences of abuse and neglect, but also exposure to extreme poverty, low parental education, as well as parental mental illness and substance abuse. And what they found was that same graded relationship in association with these risk factors amongst those children and their risk for developmental delay. A colleague of mine, Dr. Brown, out in Montefiore, also looked at the association between adverse childhood experiences amongst kids and their risk for ADHD using the National Survey of Child Health. What I want you to see here is, once again, she showed that same graded relationship between a child's, so this time not an adult, but a child's average childhood experience score and their risk for ADHD. Now, as a general pediatrician, I work out in West Philadelphia, a lovely and rich neighborhood with many strengths, but also I know a high prevalence of average childhood experiences within the community. I often identify kids who have ADHD. One of the questions that always comes to me as a result of my experience as a general pediatrician and my knowledge of the impact of childhood trauma is, how much ADHD am I seeing and how much PTSD am I seeing? And that will be the crux of our remaining talk.
Moving ahead, I will now turn to Dr. Amanda Bennett to talk in depth about the signs, symptoms, and risk factors of developmental disability.
Hello, everyone. So I'm going to briefly talk about the most common developmental disabilities that we see here in the United States. We're going to talk about some of the red flags for these developmental disabilities, as well as briefly touch on the approach to identifying those red flags and talk about some resources and referral options. So about 15% of children in the United States between the ages of 3 and 17 have a developmental disability. Some of the most common disabilities that we see are global developmental delay or intellectual disability, attention deficit hyperactivity disorder, autism spectrum disorder, sensory impairments, which can include vision or hearing impairment, and learning disabilities. And I'll just take a moment to say that the audience that we have here today are really key in helping to identify these disabilities as early as possible. Most of the time, parents will recognize that their child might have some red flags for a developmental disability, but that is not always the case. So we do really rely on primary care providers, early childhood educators, anyone that works with children in a professional capacity to also keep their eyes open for these potential red flags. So very briefly, global developmental delay and intellectual disability can sometimes be related, but they are two different diagnoses. So global developmental delay refers to a young child who is presenting with a significant delay in 2 or more domains of development. So this can include motor delays, gross motor or fine motor, speech and language impairments, cognition, personal and social development or social emotional skills, and activities of daily living or adaptive functioning. An intellectual disability is identified when an individual has impairments in their intellectual functioning, or what we typically refer to as their IQ, and their adaptive behaviors, which are their daily living skills. These impairments need to be present during the developmental period, which means that the child needs to be identified as having these symptoms before 18 years of age. And they are often not easily identified before the child is about 4 to 6 years old. Prior to age 4 to 6, we would probably refer to it as a global developmental delay. Some red flags for intellectual disability in young children can include persistent global delays, difficulty with learning new skills even when they've been practiced and presented repeatedly, difficulty with problem solving and figuring things out in their day-to-day life, a limited or a lack of curiosity for events and activities around the child, failure to understand social and behavioral expectations that are appropriate for the child's age, and any deficits, significant deficits in memory. Moving on to ADHD, the diagnostic criteria for ADHD include a child that presents with patterns of inattention and or hyperactivity and impulsivity. These behaviors need to interfere with the child's functioning or their development in other areas, and should be present in early childhood. So these should be symptoms that have been identified in the child prior to 12 years of age. In addition, we would not call this ADHD if these symptoms or behaviors could be better explained by another medical or psychiatric condition. And these behaviors are typically present in more than one setting. So this is not a situation where a child is just presenting with ADHD symptoms at home or just at school. They really should be present in multiple locations. The median age of diagnosis of ADHD in the United States is 6 years of age. It is more common in boys than in girls. Right now, the estimated prevalence is about 11% in the U.S. population. Some red flags for ADHD, children that seem like they're not listening or not hearing what you're saying to them, difficulty sustaining attention to tasks. So this can be having difficulty finishing a play activity before moving on to the next toy, having difficulty in staying present and engaged during a conversation, being more easily distracted, difficulty with organizing their activities. These are the children that are more likely to lose things or be more forgetful, more problems with carelessness. Children that have more hyperactivity or impulsivity may fidget more or squirm. They may have trouble staying seated for activities. They may be more likely to interrupt others or talk nonstop without taking a break. These children, sometimes parents will describe them as being on the go, and they may have trouble participating in an activity that requires them to stay seated or be quiet or calm for an extended period of time. They will also sometimes have trouble with waiting their turn. Autism spectrum disorder has diagnostic criteria as well. Children that have autism spectrum disorder present with deficits in their development of social communication skills, and they also present with restricted, repetitive, stereotypical, or sensory-based patterns of interest or behavior. These symptoms also need to, in order to say this is a disorder, these symptoms need to be interfering with the child's functioning during early childhood, and they should not be better explained by an intellectual disability. So in other words, this child's social communication deficits and behaviors should be significantly delayed beyond what the child's developmental level is. The median age of diagnosis in the United States right now is between 3.5 and 5 years of age, and the most recent prevalence report is 1 in 59 children. Now, some red flags for ASD in young children include not responding to their name or having poor eye contact, presenting with speech delays, or in a child who is talking, having difficulty with using their language for functional and social purposes. They may have difficulty with imitation and functional play skills, which can sometimes include understanding the process for imaginative and imitative play. They may have more difficulty with initiating or sustaining interactions with others. This can be particularly apparent for some children with children their own age. So parents may report that the child plays quite well with children who are much older, or with babies, or with adults, but they struggle with their peer group. Children with ASD can present with more repetitive movements of their body or repetitive speech, which we refer to as echolalia or scripting. They can have strong reliance on certain rituals and routines. They may have difficulty with changes in routine or changing from one activity to another. And they can sometimes present by being overly sensitive to stimuli in their environment or seeking out certain sensory experiences that are a little bit unusual for their age. Looking at sensory impairments, so the reported prevalence for hearing impairment is about 2 to 3 children per 1,000 in the United States. And for vision impairment, it's about 3% of children in the United States. And the presence of a sensory impairment can obviously play a significant role on the streams of the child's development. So a child with hearing impairment may present with more problems with speech delays. Hearing or vision impairments can impact a child's fine motor and visual motor functioning. These sensory impairments can play a role in a child's ability to develop their coordination and their motor skills, and can impact their ability to develop adaptive skills or daily living functioning. Some red flags for sensory impairments. For vision impairment, it would be a child who is not tracking objects from one side of the room to another, or not watching a parent who moves from one side of the room to another. They might have limited interest in their surrounding environment or limited eye contact, and they may present with poor coordination due to their visual deficits. For hearing impairments, a child might not respond to sounds as readily as other children. They may have delays in their babbling or their progression of other language skills. They also may not respond to their name, and they may present with an unusual vocal quality or more speech errors compared to children their age. Lastly, learning disabilities. Children who have learning disabilities present with significant difficulty in acquiring and using certain skills. These can include listening, speaking, reading, writing, reasoning, or mathematics. This is a central nervous system deficit that occurs across the lifespan, and it can occur alongside other disabilities and other environmental factors, but it is not necessary that these other difficulties or environmental factors be present. This can include social difficulties, self-regulation problems, sensory impairments, emotional disturbances, intellectual disability, inadequate instruction, or cultural differences. So again, a child who has a significant difficulty in acquiring new learning skills may have these other situations present, but it's not required. The prevalence of learning disabilities in the United States is between 5 and 6%. And a few red flags or signs that a child might be presenting with a learning disability include early speech-language deficits or delays in acquiring speech, difficulty with early literacy skills. These include skills like rhyming and early phonetic awareness. Difficulty with understanding cause and effect relationships and basic concepts. They may present with signs of academic problems or difficulty with grades in early elementary school, or they may present with an avoidance of academic activities because these skills are more difficult for them. They may have new onset or worsening behavior problems during academic activities, and they may present with more signs of anxiety or somatic complaints around school and schoolwork, such as stomach aches, headaches, etc. So, talking about all of these red flags, I think it's really important to think about ways that one might be able to identify them. And depending on your role in working with children, this can include a variety of approaches. So a simple approach is surveillance, which is just asking the caregiver if they have any concerns about the child's development. And this is really something that should be happening on a very regular basis. In pediatrics, we recommend at every primary care well child visit, the provider is just asking if there are concerns about development amongst the parents. And then at certain time points in primary care, we feel it's very important for pediatricians to also screen using a standardized measure that has defined age points to better capture more subtle delays or deviations in development. And there's a range of tools, many of which are free, but these are helpful in identifying those subtle developmental symptoms that may not present in the office in a brief pediatric or well child visit. I did want to include a few online resources available to folks. So the U.S. Department of Education has some excellent resources on early intervention, including how to find the contact information for early intervention in each state. The American Academy of Pediatrics has great resources through their Bright Futures program. Autism Speaks has excellent resources for red flags related to autism spectrum disorder. And then here at CHOP, we have two programs, the Center for Autism Research Roadmap, which is a website where providers can learn more about autism, but also put in their zip code and find resources around a variety of developmental disabilities based on the location of the child or the practice. And also we have a web-based case conference program called Echo Autism that occurs twice monthly, and the email address for the coordinator who runs that case discussion program is on this slide as well.
All right, next we will turn to Dr. Sandhyaa Iyengar to discuss the overlap of ACEs and developmental disability and how this can be addressed in a healthcare setting.
Hello, everyone. I'm honored to speak to you all this afternoon. I became interested in ACEs early in my residency when I joined a community health worker on a home visit for one of my patients. I was there to talk about an asthma action plan. But when my patient's mom opened the cupboards to give me a glass of water, I saw nothing but bare pantry shelves. At that point, I realized I wanted to better understand how to support families living in toxic stress situations that have a direct effect on their health. For that family, it meant shifting to talking about food insecurity, and I truly felt like a better clinician because of it. I'll start by introducing Joey and his story, as it is a nice jumping point to discuss some of the key issues at the crossroads of ACEs and developmental disabilities. Joey is 7 years old, and he visits his pediatrician because for over a year, his parents have noticed excessive high energy and a very short attention span to complete activities. He's like the Energizer Bunny, always on the go, and gets distracted by noises and things in his environment. Mom says it's like he doesn't even listen when I'm talking to him. He is frequently irritable and cranky, will slam doors when he's mad, but isn't aggressive. Joey has a sweet and funny personality, but all of a sudden he gets mad or sad and tearful and defensive. He doesn't like school and doesn't always hand in his assignments, but is meeting academic benchmarks. He complains frequently of vague stomach aches and headaches, typically when he has to go to school, but is otherwise healthy. It takes Joey at least 90 minutes to fall asleep. He will toss and turn and wakes up frequently in the middle of the night. Mom has anxiety and depression. An older brother is diagnosed with ADHD. Joey lives with his two teenage brothers, parents, grandparents, uncle, and cousin in an inner-city apartment. He has no physical exam abnormalities. So taking in all that information about Joey, what do we think is going on? Joey is certainly having trouble, and we want to help him, but first, we have to figure out what we are going to target. Is it ADHD? There's certainly the cluster of hyperactivity, impulsivity, and inattention symptoms, a family history, and many symptoms present in multiple settings. Is it a mood disorder, thinking of Joey's outbursts and crying episodes and difficulty controlling his emotions? Is it a learning issue, in which Joey's avoiding school because of the pressures of not understanding academics? That could present with somatic complaints like stomach aches in the morning. Or, knowing how important sleep is for behavior and well-being, are Joey's long-standing sleep difficulties catching up to him? We know that being distracted, cranky, and not able to pay attention are all related to poor sleep. Or, taking into consideration what we have been talking about regarding the pervasiveness of ACEs, could these behavioral symptoms be manifestations of toxic stress? One of the things that attracted me to the field of developmental pediatrics is that we try our best to carefully think through this list of differentials and more, making sure we have a comprehensive understanding of the child. And that underscores Dr. Bennett's earlier point that whenever there is a concern, referral is the most important to tease us apart. So, thinking of Joey, or similar children to Joey that you might have come across, how do we help? What's your next step? Take a moment here to think about your answer. There really isn't a wrong answer. I just wanted to get a sense of everyone's thoughts here. See if the poll is open. Yes.
We'll just give it a couple seconds. All right, one more second to put your response in. Again, no wrong answer. Just want to get a sense of where everyone is. Okay, so as of this moment, it looks like a majority of people would like to dig deeper. We do have some folks that are thinking about behavioral therapy or mental health counseling. So great. So let's say that we decide to dig a little deeper. So you notice mom is shifting uncomfortably in her seat, and she starts to say something, but stops. You ask, is there anything else? Perhaps as your hand is on the doorknob, getting ready to leave. Mom answers, no. Inspired by your trauma-informed trainings, you decide to try again. You take a seat next to mom and say, sometimes families tell me that things can be stressful at home. Is that something that you are experiencing? And that is how you come to learn. Dad has been in prison for 3 years and returned home several months ago, unemployed and unhappy. Mom and Dad yell at each other constantly. About a year ago, Joey witnessed his cousin being shot just a few blocks away while riding his bike. And now Joey doesn't want to go outside. And despite mom and grandparents all working full-time jobs, bills are high and there doesn't seem to be enough money to cover it all. In his young life, Joey has already experienced 3 ACEs. When you see Joey again 10 months later, he continues to have trouble with paying attention, impulsivity, and hyperactivity. A stimulant medication was briefly tried, and Joey and his teachers both thought it was helpful for a short period, but the prescription wasn't refilled. Joey is not yet receiving behavioral therapy or mental health counseling. He has frequent crying episodes when things don't go the way he expected, which can escalate into outbursts. And at school, behaviors have gotten to the point where mom worries he's already been labeled a bad kid. So Joey's case highlights several important issues at the crossroads of ACEs and developmental disabilities. For one, there is significant overlap between the symptoms we attribute to each of these conditions. Also, for some children, we can miss key aspects of their story by hastily attributing things to a preconceived diagnosis, but it might really reflect a traumatic history. For those exposed to ACEs, there seems to be a higher odds of ADHD and other diagnoses. But just to be clear, there is no evidence that ADHD or other developmental disabilities are caused by ACEs. But there are important correlations that we will dive into in a moment. We also observe a higher risk of adversity in ACEs for children who have a developmental disability. And lastly, there are disparities that must be addressed at this intersection, in which we have some evidence that kids with developmental disabilities and ACEs are getting delayed access to health care. So there's a lot to unpack in this list. Over the next few minutes, I will share what we have learned from important studies that try to answer our questions. But far too often, we don't have the detailed answers that we crave, and much more investment is needed to understand this complex relationship. So developmental disabilities are a heterogeneous group of diagnoses, but there are salient red flag symptoms that help us hone in on them, as Dr. Bennett discussed. And ACEs, as Dr. Wade told us, can present with a wide host of physical, mental, and behavioral health symptoms. Where they overlap, that area is rife with confusion, as you might imagine. Several studies cite the behavioral and developmental symptoms that can be seen in ACEs that also trigger an evaluation for a developmental disability. They include symptoms like depressed mood, difficulty with executive functions like organization, academics like literacy and math, attention, and social problems. In fact, in one study, students who had endured 3 or more ACEs were 32 times more likely to struggle in school. Some of these symptoms are related to specific ACEs. For example, exposure to domestic violence and maternal depression were found to be associated with temper, aggression, self-harm, and sleep disturbance. So of U.S. children with a diagnosis of ADHD, reports from the National Survey of Children's Health have shown that 70% have been exposed to ACEs. What this tells me is that we can't ignore childhood trauma when we are talking about ADHD. It must be a part of the conversation around diagnosis and management.
In data from a U.S. national survey, researchers found that children with ACEs were more likely to have parent-reported ADHD compared to children with no ACEs. Children with socioeconomic hardship, divorce, familial mental illness, neighborhood violence, and incarceration were significantly more likely to have ADHD. 4 ACEs correlated with a 4 times odds of having ADHD. There was also a graded relationship with the total ACE score and parent moderate to severe ADHD, which adds to previous studies showing that cumulative exposure to childhood adversity is associated with worsening ADHD severity. Other studies of different populations agree with this correlation between early traumatic experiences and the increased odds of an ADHD diagnosis. What's more is that compared to children without ADHD, studies have shown that children with ADHD have a higher prevalence of each ACE and the cumulative ACE score. Similarly, in a national survey, researchers found that U.S. children with autism spectrum disorder had a significantly greater probability of exposure to 1 to 3 ACEs and 4 or more ACEs in comparison to peers without autism, even after controlling for poverty. Specific ACEs with a higher prevalence in autism were exposure to neighborhood violence, parental divorce, mental illness, and substance abuse. After controlling for age, sex, race, family structure, and poverty, children with autism were 1.66 times more likely to have multiple ACEs compared to children without autism. When further analyses were done, they found that the increased rate of ACEs in autism was driven by the greater co-occurrence of behavioral and emotional problems. And another important adversity that occurs in childhood is bullying. Children with autism are bullied at a rate 3 to 4 times that of their peers, with negative impacts on academic functioning and increased risk for suicidality. Children with autism who experience ACEs are also at an elevated risk for comorbid psychiatric and medical health problems. Unfortunately, less attention has been given to the relationship between other developmental disability diagnoses and ACEs. We do know that in a graded fashion, children with ACEs were up to 5 times more likely to have a developmental or mental health condition. The strongest effect was seen for young children aged 2 to 5 and those living in households with incomes below 200% of the federal poverty level. And in a Dutch sample of children with intellectual disabilities, 83% and 50% experienced 1 and 2 or more ACEs, respectively. And children with a developmental disability also have increased risks for exposure to specific adversities, namely neglect, physical abuse, and sexual abuse. These risks are particularly heightened in light of immature social skills, cognitive delays, and higher likelihood of physical punishment for behavioral difficulties. My colleagues and I are trying to evaluate the impact of ACEs on specific behaviors and functioning for children who have a developmental disability. We looked at a sample of children referred to developmental pediatrics for an evaluation and noted that children with at least 1 ACE had more severe functional impairment at home, but not at school or with peers. There was also increased sleep disturbance, more toileting difficulties, and for low-income families, we observed an increased risk for obesity. More studies will need to evaluate what kind of physical health and behavioral and emotional consequences exist for ACEs in children who have a developmental disability, so we can design the best interventions to mitigate these risks. So the science of brain development tells us so much about how toxic stress impacts development. Stress itself is not bad, it is necessary. For example, if we were to find ourselves face-to-face with a tiger, the hypothalamus pituitary adrenal axis would kick in, the heart races, the inflammatory system is activated, hormones surge, and that allows us to fend off the tiger. Afterwards, the heart rate returns to normal, everything cools down, and hormone levels drop back. But what about when that tiger comes home with you? When you can't escape it? Then the fight or flight response is continually activated. This compromises the immune system, burdens the cardiovascular system, and even changes the expression of genes. As Dr. Wade spoke about, high sustained levels of hormones in the HPA axis result in abnormal development in parts of the brain like the hippocampus, which is critical to both learning and memory, the prefrontal cortex, which is responsible for executive functioning, and the amygdala, which is where fear, emotions, and decision-making processes reside. To date, few studies have investigated the relationship between exposure to ACEs and children's healthcare access. For children with autism, ACEs have been correlated with unmet physical, mental, and dental healthcare needs. Compared with children without ACEs, the adjusted effects of 1 to 2 and at least 3 ACEs resulted in significantly prolonged time to autism diagnosis, which with children with none, 1 to 2, and 3 or more ACEs diagnosed at a mean age of 4.3, 5.2, and 5.7 years, respectively. Also, for children with autism, report of 1 to 2 and at least 3 ACEs was also associated with a 22% and a 27% increase in the median age of entry into services. And because early and sustained intervention for children with autism is associated with the best prognosis, this delay in diagnosis and initiation of treatment associated with the presence of ACEs is clinically meaningful. Much more work is needed in this area, and we need to understand the relationship with interventions for a wider variety of developmental disabilities. We can theorize that these disparities in care occur in the context of significant family stress when there is a history of trauma. Children with developmental disabilities often require intensive therapies like applied behavioral analysis, typically 20 to 25 hours per week, in addition to a slew of therapies like speech therapy, occupational therapy, physical therapy, special education, social skills groups. This often requires financial means and a certain level of savviness to navigate complex mazes of referral, scheduling, and transportation. We theorize that acquiring resources, even when available in the community, is even more challenging with a history of trauma. Another aspect is juggling family demands like siblings and limited time off work. And there's also an emotional toll that families talk about, the stigma of mental health and the lack of empathy for the general public has for children with behavioral difficulties. And the accumulation of daily stress likely has more consequential effects for families living with a trauma history, with the end result of needing additional layers of support to get this needed health care. The work of Heckman, Nobel Prize winner in economics, tells us that these early interventions are very important. Interventions in the early years of life give us the best foundation and have the best rate of return on outcomes like education, employment, and health compared to remediations later on. Thus, addressing disparities with access to diagnosis and interventions are especially urgent. I think this is best summarized by Frederick Douglass. It is easier to build strong children than to repair broken men. So let's check back in with Joey. Using a community resource that I will show you later, we found a trauma-informed parenting class that parents expressed interest in because it was held in Spanish and it was located nearby. Joey now meets with a counselor once a week after school where he can process his experiences, and he's also found an artistic expression that he enjoys, painting. He does continue to have an ADHD diagnosis. He gets accommodations in school that give him access to movement breaks and seating close to the teacher, which has been helpful. He also takes a long-acting stimulant, which helps his energy and focus during the school day. In a moment of pride, Mom shows you a picture on her phone of Joey earning Star Student of the Week for helping out his classmates. And while the path forward will likely continue to have many challenges, Joey's story shows us how addressing early childhood adversity and behavior has great potential for great improvements. So transitioning now into thinking about what we can do to support these children and their families. My first piece of advice is to keep in mind the impacts of childhood adversity on behavior and development for every child. Time and time again, studies have shown us that these stressful experiences impact us all, regardless of race, insurance status, or geographic location. And I don't mean to downplay the disparities in exposure to ACEs that do exist for some communities, but I do want us all to keep ACEs on the radar for everyone. Secondly, all providers can strive to create a safe, welcoming space. Practically speaking, what that might mean is setting clear expectations and taking the time to say, "I'm so glad you are here." I encourage everyone to make it part of their practice to ask about stressors and potentially consider formal screening. For the pediatricians in the audience, here is one example of screening for ACEs that I like because it embeds ACEs questions in questions about overall health, like eating fruits and veggies. And I say thoughtfully screen because consideration is needed for how that will be done, electronically or written, at the visit or before, and make sure you know what you will do with a positive screen. So a question that some of you may be asking yourselves is about the possibility of misdiagnosis that comes up when a child is presenting with symptoms that are found in both a developmental disability and with exposure to adversity. And I don't consider this question as an either or, because both can really play a role to help to understand and help the child. If we miss out on the trauma, we have failed to capture a really important element of a child's story, and we are missing the opportunity to get them on a path to true well-being. It can play a role, especially when there is suboptimal response, for example, to stimulant medications and targeted behavioral therapy in a child who's manifesting the symptoms of ADHD, but who also might have been exposed to multiple traumatic stressors. And we theorize that chronic stress can even downregulate neurotransmitter receptors, which could affect the response to stimulant medications. So ultimately, what could help is working in interdisciplinary teams, using trauma-informed modes of therapy, and making sure medications are at the lowest effective dose. So will knowing a trauma history change our plan in caring for a child with a developmental disability? I argue that it certainly can. Typically, we recommend behavioral therapy to address behavioral difficulties like aggression, following directions, tantrums, or flexibility. And using the principles of applied behavioral analysis, we describe behavior as being a purposeful way to communicate. We try to find the antecedent and the consequence for the behavior and use that to shape behavior in a positive direction. However, when a child has been exposed to significant trauma, that may not be the therapy approach needed. So, for example, in our case, if Joey refuses to go to school in the morning, it might not be because he's being difficult and non-compliant. It may be because he doesn't want to walk to school, past the block where his cousin was shot. So trauma-informed care acknowledges that some behaviors are not conscious decisions, and they lie very deep below the surface, like an iceberg. Trauma-informed care shifts to understanding coping mechanisms and functioning in light of past events, and doesn't see presenting problems as needing to be fixed, but rather attempts to understand why these problems exist in the first place. Trauma-focused cognitive behavior therapy has been adapted for use in children with autism and other developmental disabilities, but to date I am not aware of any controlled studies in this population. An alternative technique that I wanted to share is called positive identity development, which may be helpful for children with developmental disabilities who have been exposed to trauma. It is especially helpful for children with limited language and cognitive abilities, and I love how it works to build self-esteem. So, emerging neuroscience has also yielded some good news. ACEs are not destiny. If the human brain can be hurt, it can also be healed. And it is up to all of us to aid in that healing, creating communities in which everyone can thrive. So much remains to be learned about resilience in the population of children with developmental disabilities. One study found that despite higher ACEs, children with developmental disabilities did not have less resilience, which prompts asking what we can learn from families that help with the buffering effects of trauma. And researchers are starting to evaluate combinations of protective factors related to resilient functioning and studying resiliency across cultural and geographic locations as well. And the most important part of this paradigm shift is learning to ask not, what's wrong with you? A question that's freighted with judgment, but what happened to you? A question that invites dialogue, reflection, and healing. Here's some resources that I wanted to share. For those of you that are local to Philadelphia, the CAP for Kids website is how we found that trauma-informed parenting class for Joey. The ACEs Connection is a wonderful place where people are interested in being part of this community, doing this work. And I did want to highlight the Sesame Street in Communities website, which is doing a wonderful job at addressing trauma for families and has some great worksheets and resources. Thank you.
All right, so Thank you to Drs. Wade, Bennett, and Iyengar for today's discussion on ACEs and developmental disabilities. We now would like to invite the participants to type in questions directed to any of the presenters using the chat text box on the screen. We'll give everyone a few minutes to get their questions in. So I know one of the questions that we received was, how can this intersection of ACEs and developmental disabilities be addressed in non-clinical settings, such as schools or community programs or even through telehealth? And Dr. Wade, I was wondering if you wanted to maybe speak to some of the community settings.
Sure. I think there are a number of community settings in which I've experienced in my own practice, or where I've seen in my own practice. Organizations are working to address ACEs. One school system, a charter school system here in Philadelphia, has really taken a trauma-informed perspective on this work, and they've actually, trained their staff, and they also have on-site trauma services and trauma therapy for kids. One of my colleagues does group therapies with kids who have identified behavioral problems, but also have histories of trauma. But also, they've done a lot of work in terms of training the staff on how to identify, recognize signs and symptoms of trauma in kids, and respond in a trauma-informed perspective. I think I've seen a number of examples within the community where agencies have taken this approach, and I think that the content of what they do, is largely the same. Provide increasing awareness and knowledge among staff, providing training for staff on how to recognize and identify trauma and respond appropriately, and then integrating trauma-focused therapies into their practice.
Thanks so much. And Dr. Bennett, I was wondering if you wanted to comment on addressing this in other settings, like through telehealth or other types of clinical settings.
Yes, so besides the ECHO Autism program, which is focused on autism in terms of the educational component, the didactic component. However, because it is a case discussion platform, participants can bring pretty much any challenging case to the table, and the expert team that participates here at CHOP is pretty comfortable with talking through, because it's a case discussion format. We really encourage everyone to bring ideas and brainstorm on how to address the concerns that the presenter is bringing. So we certainly have had some discussions around ACEs and trauma experiences in patients where development is also a concern. I do know a little bit about the TIPS program at CHOP, which is a telehealth psychiatric consultation program where primary care and community providers can receive consultation from a psychiatrist at CHOP. And my understanding with that is that it is primarily focused on medication management and management of psychiatric and behavioral health issues, but I think that it could be another potential resource if a patient is presenting with behavioral health symptoms and a provider has questions about how ACEs could be involved. I think that's another resource. That's the TIPS program at CHOP as well. Outside of Philadelphia, I don't know as many of the telehealth resources, but I do know that in general, ECHO is a model that is widely expanding in terms of how it reaches community providers to provide access to the specialty programs at academic centers. So it is quite possible that in your community there could be a regional ECHO that addresses some of these concerns as well.
Thanks so much. We also received some questions about addressing the intersection of ACEs and developmental disabilities, and particularly vulnerable populations, such as those with gender dysphoria or perhaps children who are immigrants. And I was wondering, Dr. Wade, if you could speak to that.
So I think I can particularly speak to immigrant populations as well. I think I can let some of my colleagues talk about some of the other areas that Dr. Huang mentioned. So I think we know that individuals who are coming from countries outside the United States may have experienced trauma and challenges as a result of their transition to our country. As a matter of fact, when the average childhood experience study was first published, the World Health Organization actually convened a body of experts to develop a broader measure that really captured some of these experiences in terms of that immigrants might have navigated in terms of leaving their home country. I think one thing that's important is to understand, and this is something I didn't bring up in my talk, is that the concept of adversity is something broader than what was initially considered in the initial average childhood experience study. Those 10 questions don't capture the range of traumatic and stressful experiences that we know impact the health and well-being of kids across their life course. And we've actually, I've been a part of a group here in Philadelphia that's conducted some follow-up studies, trying to broaden the concept of adversity to include some of the neighborhood factors that we know impact health outcomes. But there have been an array of different studies that have looked at poverty, that have looked at racial discrimination, that have looked at other adversities as well that we want to be capturing as well. I think the key point in terms of managing this issue is, in terms of immigrant population, is connecting to many of the resources that are already available in the community, which individuals might have also already been connected to that might actually help them in terms of addressing their adversities.
Great, thanks so much. We also received some questions about the prevalence of ADHD as well as autism spectrum disorders. Maybe Dr. Bennett, you can speak to those questions.
Yes, so those numbers, those prevalence rates came from the Centers for Disease Control. The ASD prevalence rate was reported in 2016, I believe. I might have the year wrong, but it's the most recent prevalence rate that the CDC reported. They work with a number of states across the U.S. to collect data on 8-year-olds that currently have an autism spectrum diagnosis, and that's how they come up with that number. So the number is slightly increased from the last report, which was 1 in 68, but not increasing at the rate that it was over the past 10 years. So I guess that is somewhat good news. The prevalence rate for ADHD is a little bit trickier because those numbers are usually reported in age groups. So the number could be slightly higher closer to the maybe 13 to 15% range if you look at teenagers, but it's quite a bit lower if you look at early elementary school age. And so that number of 11% is an average reported prevalence. There was a quick question about how to support educators in addressing autism symptoms in a school district setting. The Echo Autism that we host is a free program, and the educational topics are sometimes a little more medically focused because we are a medical institution. However, we invite and encourage anyone who is interested in learning more about autism to participate. It is a great resource for discussing as a group and learning as a group, and as the experts, we have learned a lot as well from the participants. So that is something that I would encourage and would love to see people sign up and participate in the future.
Great, thanks so much. We also received several questions about where to refer families who screen positive for ACEs, where in the community or in the healthcare setting they should go. And we also received some questions about resiliency and ACE score and whether there are measures for that. So maybe Dr. Wade can speak to those.
So first, in terms of the first question, in terms of where to refer kids who have high ACE scores, what I want to remind people is that, ACEs are not deterministic, right? So just because someone has a high ACE score doesn't mean they necessarily are going to have lifelong health problems and die 20 years earlier than expected. Which is why I think that question about resiliency and what protective factors are in place is important. In terms of where to refer patients, I think you always want to take the step of going back to the patients, right, and understanding their experience of adversity and what protective factors they might have. And then, particularly, I know I'm biased because I'm a pediatrician, connecting them with their primary care pediatrician, right? And so oftentimes, particularly when patients are discharged from a hospital setting, I'll get a report about why they were admitted to the hospital setting, if they had a pneumonia and what medications they were treated. I think it would be wonderful, right, if these challenges were identified as part of that visit, if that was conveyed to me as well, because then I can connect with them and follow with that family and make sure that they're connected to a range of resources that can help them to address the individual adversities that the child or the family may be experiencing. In terms of the question about resiliency, what I also want to state is that just like adversity has been poorly conceptualized and, the different constructs that are within adversity or childhood adversity range, vary depending upon what study you may be looking at, resiliency has also been poorly conceptualized as well. And I think one of the challenges, there's a measure called the Brief Resiliency Scale, which largely captures individual resiliency. And I think when we think about what are the factors that really help kids to bounce back from these experiences, to restore to their normal homeostasis, and more importantly, to flourish and develop, it's really largely about connection, right, which is not necessarily an individual skill. And so what I want to encourage people when you think about resiliency to be thinking about what are the strengths and protective factors that exist within the family, how connected or isolated does that family feel, or what's the experience of connection and networking with other families and individuals within their broader community, and what sort of supports they already have in place. And I think that's probably more important when thinking about what sort of protective factors or resiliency factors you want to try to identify.
Thank you. We also received a question about how to manage behavioral expectations and how that plays a part into assessment of development and ACEs as well. Maybe Dr. Iyengar, you can speak to that.
Yeah, sure. So one thing I always like to remind parents is, especially when we're assessing for a child with a history of trauma, we have to think about the child's chronological age and remember that it may not be the same thing as their developmental age. And we see that often for kids who have been exposed to adversity. It's almost like going back to that slide, looking at the parts of the brain that chronic toxic stress affects. It's almost like developmental hijacking that's caused by ACEs. So you think about a 16-year-old who may look like a 19-year-old because of her makeup and clothing choices, but has only the decision-making capabilities and the emotional maturity of a 12-year-old. But then socially, she's clingy and awkward in social situations with strangers, like a kindergartner. So you may see this kind of scattered development, and that's really important to explain that to parents so they can adjust their expectations and also be patient with a child over time, especially when there is that history of trauma. So I think that's an important point I really try to share with families.
Thanks so much. And just a note, we received several questions about the slides and the resources, and yes, they will all be available. The slides, the resources, and recordings will be available. Please check your email. That will be the thank you email that will be sent to you at the end of the recording, end of the webinar. I'm sorry. And we're just looking through some of the other questions. There was one question about, whether there were any resources available for siblings in families of children with developmental disabilities who may have been exposed to ACEs. And I know at the Children's Hospital of Philadelphia we have sibling workshops where siblings of kids with different conditions can come in and they meet with a therapist on a monthly or weekly, on a regular basis, and it's a kind of a safe space for them to be able to talk to each other and relate to each other that way. Oh, there was also a question about ABA therapy and how effective can it be in a child who has experienced trauma if they're working with a provider who may not be aware of how to do that. So maybe Dr. Bennett can speak to that.
I will try. So the principle behind applied behavior analysis, or ABA, which is the recommended therapy for children with autism spectrum disorder, which has the most evidence behind it, is that you are trying to better understand the function of the child's behavior through collection of a lot of data around the child's behavior. So ABA, to my knowledge, is probably not 100% trauma-informed in its approach. However, I think that a good behavior analyst who is spending time observing this child's behavior can probably still recognize if there are functions of the behavior that are related to a past history of trauma. So a good clinical therapist, a good behavior analyst should be collecting information on the history of the child and the family dynamic as part of their data collection to understand the function of the behavior that they are trying to change. That may not always happen. That's going to be dependent on the therapist's level of experience and comfort with that particular area of expertise. I think it probably is pretty challenging to find an ABA team or an ABA agency that specializes in also trauma management, but knowing that the risk of ACEs and developmental disabilities being related is so high, I think more and more ABA experts are running into this challenge and learning how to do this in an informed way.
All right, great. Thank you, Dr. Bennett. We also received some questions about alternative therapies or broadening the concept of treatment. Dr. Iyengar, maybe you could speak to that.
Yeah, sure. So certainly when we think about a child's overall well-being, there's so many factors that come into play, especially when children are living in complex environments and maybe been exposed to significant adversity in their life. I do think that we need a multifaceted approach to well-being, and so that can include things like I mentioned, Joey and the art that was helping him heal so much. We see a lot with different kinds of movement therapies, for example, yoga for kids. Sometimes I have actually seen one that was kind of like trauma-informed, kind of a yoga class, and people are being very creative, and I really admire that sort of work that is trying to come at the perspective of what is a priority for the family and being respectful of culture, and also, again, expanding the idea of well-being to be more than just physical health, and utilizing all kinds of modalities to our benefit. So I don't think that there's very clear studies or evidence at this point, but I do think that it's an exciting area, and I do encourage my families to pursue all kinds of healing approaches.
Great. And we also received a question about when children are referred to the ED for behavioral issues and potentially they may be sent out to inpatient psych wards. There's maybe some concern that they may not be getting effective treatment for the trauma. Dr. Waite, can you speak to this?
So as a general pediatrician, I work in a primary care setting, but I also work in an array of different CHOP community-based healthcare institutions across this region. And so I have my own personal experience with kids who have come into our facility, been admitted to our pediatric service, get discharged to an inpatient facility for behavioral problems, and then a couple months later come back through our facility with the same concerns. And so I can commiserate with your concerns around these challenges. What I can say is that I think these organizations are largely doing a wonderful job in terms of trying to navigate these sort of complex challenges that these kids face. We also know that they're multifactorial in nature. They may be trauma related, but they also have their own, organic, behavioral problems as well. One of the things I think the city's doing really great here in Philadelphia, and I don't know, in terms of the country, but here in Philadelphia, we have a wonderful network of behavioral health organizations through our community behavioral health system that's largely, tried to take on this challenge, and they've created what they call the PACS network. And all of them, what they've come together to do is to really become very trauma informed and trauma focused in some of the services they provide. And so they are, with all their clients, they are working to identify kids who have been ACE impacted, make sure those kids on an outpatient basis are receiving the trauma-focused services that they need that are evidence-based, and then working together in terms of professional development to make sure that they're all providing high-quality care. And so, they meet on a monthly basis, present cases, bring in experts to talk about trauma and talk about trauma-focused therapies, and are always doing in-services around, building up the quality of care that they provide. So I think that's been one resource here in Philadelphia that is really helping to address that issue, helping kids to receive trauma-focused services on an outpatient basis and not necessarily have to go into inpatient facilities. But I also recognize that that's a huge challenge that I think goes through many EDs across this region, and I imagine across other cities in our country as well.
Thank you so much. We also received some questions about challenges with assessing for ACEs and also developmental disabilities in certain populations, and especially in kids who may be nonverbal. Maybe Dr. Iyengar, you can try to address this?
Yeah, sure. I think that's a great question. I think that really speaks to some of the challenges that we're seeing with developmental delays and different disabilities that we can't directly, for example, ask a child. But that's where screening comes in. And so typically when we're screening a child for ACEs, we're asking the parent those questions. So one of the screening tools that I had put on one of my slides was for the pediatrician to ask in the setting of a well child visit. And I think that's a great context to be screening. And we're not waiting to see particular red flags in a family to then delve in deeper. Screening is really universal and should be. We're hoping that pediatricians will start to do this kind of more regularly, so we can pick up on ACEs and in kids with developmental disabilities who are nonverbal, etc. We're not asking the child directly, but we're screening the parents for the child's experiences or the family's experiences.
So this is Dr. Wade. I just want to follow up on that. I think that is so right. It's one of the things that I've been really trying to advocate more for, is for pediatricians to take a leading role, or general pediatricians to take a leading role in this work in terms of trying to identify adverse childhood experiences within our families routinely as part of our well child visit. And there's been a huge amount of pushback in that area in terms of we're asking these questions and what do you want us to do with this information. I'm going to steal something from one of my mentors, Joel Fine here at Children's Hospital of Philadelphia, who talks about the power of ACEs knowing, right? And so he actually has moved me away from the concept of screening to more assessment, because assessment really talks about, this is part of my broader understanding of this child's health and well-being and many other factors that are influencing that child's, well-being and health. And so I think, I like that idea, because it really moves me away from this idea that I have to necessarily that as part of this ACE screening, there's something medically, relevant that I'm going to necessarily have to do, right? I may be, part of the power of this information is that what we know about trauma is that individuals, because of their experience of trauma and the way trauma marginalizes you tend to bury those experiences. You tend to internalize those experiences within yourself. And because I'm this primary pediatrician who has developed this longitudinal relationship with the family, I may be the only individual who they have a supportive relationship with, who they trust to actually divulge this information. And I know as a general pediatrician, if they can actually get it off their chest, it allows us to create a conversation that then externalizes it, right? That moves us to, this away from the self-blame, right? And it helps people to rewrite their own narrative because they have that trusting relationship with me. I know that there are, an array of different organizations who have already started this work. In Montefiore in the Bronx, they routinely do an ACE assessment for all newborn families who come in. One key point that I want to highlight is that they don't just assess ACEs within the child. They ask about ACEs in the parent. Much about this work that I think we're starting to realize is, one, the intergenerational impact of ACEs, right? That one's experience of adversity as a child can actually affect your offspring, can affect their health and well-being through an array of different factors. The connection, right, between a parent's, ACE score and their child's ACE score, I think is another area that's starting to emerge. And one, it's this unique opportunity to really have a discussion with the family around how ACEs impact health, and to think about ACEs as an outcome, right? So one of the things they do at Montefiore is they do an ACE assessment for their newborns and their parents. They get the ACE score of their parents, which unfortunately usually is quite high. We're talking about in the 4s or 5s. But then they get an ACE score for that child. And what it allows them to do is have a discussion about the life course impact of ACEs, and have the parents then look at their child's ACE score and figure out what are some of the ways that they can work to keep their child's ACE score down. So their child's ACE score is already a 2. How can they work to keep that ACE score from becoming a 3 or 4 or 5, which I think, then can improve outcomes for families and for kids.
Great. And just as a reminder, we're going to be wrapping up shortly, so if you have any questions, please type them in now. There was a question about, what our experience has been with getting counseling resources from families and, in thinking about the payer or financial perspective or affordability. Maybe Dr. Iyengar, you can address this?
Yes, I can certainly try to address it. It's definitely a complex question, and the answer does certainly depend on the location. I know, being where CHOP is located in a tri-state area, we see families from different states and different communities, and we see that the ways that families end up accessing these resources and treatment modalities varies greatly. So it can be through private or public insurance. We often see families actually going into using like faith-based resources and different smaller community organizations to access therapy. And so for Joey's example, it was actually a small like a nonprofit that was working, through a faith-based organization. So I think that we have to certainly be really creative when we're looking for resources, and I think that underscores the importance of being part of a community. So through, like, for example, the acesconnection.com, there's a lot of discussion around what's available in certain communities. So that's a nice place to try to get a better understanding in your area. But it is a really difficult question, and I don't have specific answers for that. Okay.
Sorry, I just want to follow up on the question around, someone said this presentation should be directed toward Philadelphia schools because educators have this more longitudinal relationship with families and kids. I agree, and I think one of the comments that the person made was that that we should be having therapeutic groups with students. This work is actually already ongoing. I think I mentioned it. It's not to my knowledge, it's not happening routinely across the entire Philadelphia school network, but particularly Mastery Charter Schools has a group of schools that's already doing work around this, where they have counselors who come on site. And identify kids who have histories of trauma and are doing these therapeutic groups as well. And I agree. I think that we need to be leveraging these places where we have these longitudinal relationships with families. I think healthcare is one, and general pediatrics is one, and family practice is one. Our educational systems are another place, right, where we can identify these experiences upstream, provide the services that kids need early so that we don't see the manifestations of the experience of trauma later.
Great, thank you. So this concludes today's webinar. We ask that all attendees complete the online REDCap survey that will pop up when we end the webinar. And as a reminder, if you are a social worker or nurse and would like to claim continuing education credits for the webinar, you are required to complete the survey. And if you are a top employee requesting nursing continuing education credits, please remember that you will need to complete the evaluation in CHOP Learning to receive your certificate. And again, the resources given at during today's presentation will be provided in an email participants will receive at the conclusion of the webinar. So thank you so much. This was a terrific, engaged group of participants, and we really appreciate all that you do to protect and enrich the lives of children. And we hope this webinar was useful and actionable for you. I also want to thank our presenters, Drs. Wade, Bennett, and Iyengar. Please remember to take the time to complete the survey that will pop up when we end the webinar. And at this point, we are ending the webinar. Goodbye.